presentation is actually oriented toward the practitioners, and I want to give you an idea how to diagnose and possibly treat patients with pandas. I'm going to make it very simple, very mathematical, so there will be, no misunderstandings. This is just a short description of population that I have worked, and actually the data that will be presented here are from a select group of about 202 patients. A reason I didn't include the rest of them, well, we don't have a complete one-year follow-up. Some of them have fallen from the follow-ups, etc. So we have chosen by accident these 202 patients. Population that I have worked with actually pretty much defines everything that we know about the pandas. It is usually in children, onset is usually in children less than 8 years old. The distribution among sexes is about 2 to 1, okay? And what is also fascinating, just in the medical history, is that if child's presenting main symptom should be the OCD, you will likely find some obsessive compulsive history on the mother side of the family. However, if the tics are main presenting symptom, you are likely to find it on the father side of the family. I don't have an explanation, so we're just gonna move on, okay? Now, what I wanna go with you over, it's a very distinct group of symptoms that pandas patients present with, and I'm gonna supply you with the percentages of incidence of those symptoms. Now, incidentally, my data were compared to Dr. Latimer's data and then to Dr. Svido's data by people who were independent of three of us, and we found that the data were actually matching in about 1 or 2%. So I would take them as accurate. Okay, I have decided to split it for better understanding in two groups of symptoms. First group I call behavioral symptoms because I didn't have a better name. That's an obsessive compulsive symptom, and that symptom has been present in all patients diagnosed with pandas. Further behavioral symptoms are the behavioral regression. What that really means, where the child behaves younger than the chronological age. So, if you have a 4-year-old child in your office who is sitting in mother's lap and sucking her thumb, that is normal. If you have a 14-year-old girl who is sitting in mother's lap, sucking her thumb, that's abnormal. So, among these behavioral regression symptoms, there is a separation anxiety, and that's the one that has fascinated me the most, because what is actual explanation for it? And the only explanation I found in literature is actually from chronically tortured prisoners from Turkey that were described developing first separation anxiety, then regression, and then autistic-like symptoms. So I think, chronic stress in this patient and being terrorized by symptoms is what may be the source of the symptom. The next one is the sleep disorder. That one in my population has been present in 84% of the patients. Then there is inability to concentrate, hyperactivity, and inattentiveness. And as you can see, each of these has the exact percentage. So inability to concentrate, it's 87%. Hyperactivity, 71%. Aggressiveness, 62%. Short-term memory impairment, what we're going to reflect later on, it's in 62%. Deterioration in learning abilities, particularly math, and that is fascinating because a lot of these children retain perfectly normal ability to read. However, they lose the ability to write, and they lose the ability to do math. hallucinations in my population have been identified in about 9% of the patients, but personally, I believe they are higher than that. Anorexia or restrictive eating we had in 17% of the patients. Selective mutism was present in 3% of the patients. And then emotional lability and depression that I actually originally did not include in my symptoms. I did it after Dr. Svitos and Dr. Latimer, we discussed that. So I had to go back into the records to find it. That appears to be present in about 61%. Now, those are the symptoms that you are likely to observe, but even more likely you're going to be reported on those symptoms and you're not going to see them. But there are symptoms, and I call them physical symptoms, that actually can be present at the time of your office visit, and this is something I would like to remember. These children have almost uniformly hyper alert appearance. They look like something is going to happen. They are ready to jump, okay? Also, if you look very carefully at their facial expression, you're going to find that there is impairment. Their face is mask-like. You can call it puppet-like facial mannerism, okay? There is a deterioration in fine motor skills and handwriting, and that's identified in about 89% of the patients. Urinary frequency, daytime accidents, enuresis, 88% of the patients. Also, during the acute stage of illness, very frequently patients present with the marked madrasis or dilatation of pupils, and they look like they just saw the devil, okay? So that is something that is kind of fascinating to see. After that, we go to the abdominal complaints. That is something that has been present in 79% of the patients, and I think it deserves eventual an explanation because frequently the abdominal pains start before actual psychiatric symptoms. So they don't get a stomach ache because they're upset. They're upset possibly because they're getting stomach aches, but that's something that needs to be investigated, okay? One other important symptom is increased sensory sensitivity. These children suddenly become very sensitive to light, they become sensitive to sounds, they become sensitive to touch. Finally, among the physical symptoms already mentioned, tics and adventitious movements. So what I have done, I have gone through all the records and I have tried to figure out statistically the data that we obtained, how they fit the patient population, and how much help we get from the laboratory data. So we found positive GABS titers or gas titers. We found in about 42% of the patients at the time of evaluation. However, taking the medical history and figuring out if there was a preceding group A strep infection, or was there somebody in the house who had a group A strep infection, okay, we found that in one other 40% of the patients. So when you combine these two groups, in this particular patient population, 76% had a positive streptococcal indices that were related to the onset of the illness. I have demonstrated about 18% of the patients had positive antinuclear antibodies, usually the speckle pattern. There was an elevated IgE in about 29% of the patients. So those are the laboratory data we have done. I have done Dr. Cunningham's panel on a small number of patients, and the reason I have not done it anymore was simply at the time it was very expensive test, and these parents were already financially exhausted, so we had to kind of omit it as a part of initial workup. I hope we can do it now more frequently. As a part of the workup, we would do the trial of antibiotics. Personally, I preferred beta-lactam antibiotics, and if the child was allergic to penicillin and or amoxicillin, we would use Zithromax. We would give him that to the child for 14 days and evaluate the response. If the child had a significant positive response, and when I'm speaking about significant, let's talk numbers. If child was 75% or better, after completing the 2 weeks of antibiotics, I would abstain from the steroid burst and just watch the child and see what happens. If, however, child was 75% or less better upon completion of antibiotic, I would give them 5-day steroid burst, what is a simple procedure, 1 milligram per kilogram as a single dose in the morning, and then observe them for additional 2 weeks. If there was a 75% or more improvement during those 2 weeks, the steroid burst would deemed positive. If it was 50 or less % positive, then it could be a parent's imagination or whatever, I would consider it negative. Oops, sorry. Now, when you work with a large population, you have to have a system to work these patients up, not only by laboratory, but you have to have a system how to diagnose them. And so what I have found is that it would be nice to have a certain diagnostic criteria and then a formula how to arrive to diagnosis. And here it is. Okay. I divided it into 3 groups. One is so-called absolute criteria. Second is major criteria. And the third group is a minor criteria. If you feel there is a resemblance to the Jones criteria, you are right. I just copied it for this disease, okay? So, absolute criteria is sudden onset. When we are speaking about sudden onset, it is a child develops suddenly, overnight, severe symptoms. Those symptoms develop in few hours, rarely 1 to 2 days, but never longer than that. The most characteristic thing that comes with it is that the parents are almost always able to tell you the date of when the symptoms started, and frequently the hour, actually, when the symptoms started. The major criteria that I have elected to use would be separation anxiety, and there are actually 2 types of separation anxiety that haven't been defined, properly until now. There is a separation anxiety, let's call it subtype 2, where the child is physically dependent on the mother or the caregiver. They follow the mother or the caregiver every inch of the way during the day. Mother goes to the bathroom, they sit in front of the bathroom and cry. That is characteristic of children 10 years or younger. In children 10 years or older, there is a different type of dependency. And I call it subtype 2, if you want, but those children become actually dependent on a familiar physical environment. So they start preferring a certain room in the house or the house, and they refuse to go anywhere else. They refuse to go to school, they want to be home. They don't want to visit grandma, they want to stay home. So those are those 2 types that we are working with. So major criteria, number 1 would be separation anxiety. Second would be the obsessive-compulsive symptoms. Third, and we can discuss it a little bit later during the panel, tics and adventitious movement. And fourth, major criteria would be restrictive eating or anorexia. Now, just for a matter of clarity, I wanted to present that there are actually two different types of restrictive eating and the reasons for them. Let's call it subtype 1. I'm obviously into subtypes, okay? Where the child doesn't eat because he has a fear of choking on the food, fear of vomiting after ingestion of the food, okay? Or inability to swallow because of intolerable smell, textures, or whatever. The anorexia subtype 2 would be distorted body image. What I have noticed, and I think my colleagues would agree to an extent, is that in children, younger children, the onset of illness, usually the subtype 1 is that starts it. Restrictive eating due to the distorted body image is usually something that follows it later on. All right. Now, the third group are minor criteria. Those criteria have been, I listed them for you before, but let's just go over them together, okay? Again, I split them into behavioral symptoms and physical symptoms. Even though it's not perfect denomination, I accept that. But it's very helpful for the formula that we're going to develop later on. So we have minor criteria would be sleep disorders, behavioral regression, emotional lability and depression, coprolalia, aggressiveness, hyperactivity, learning disability, and hallucinations. Minor criteria, let's call them physical, it's a group 2, would be hyper-alert appearance, puppet-like, or this mask-like facial expression, dilated pupils, urinary frequency, and enuresis, or daytime urinary frequency, incontinence, short-term memory loss, increased sensory responses, fine motor skill deterioration, and disturbances of writing, dysgraphia. If you look at it very critically, this is not perfect. What actually works is that the formula that is going to come now works exactly with this setup. So please feel free to call this physical symptoms, whatever you want to do, but leave them in the group 2 because formula requires it. So finally, I have arrived to, I believe, formula that has been tested on about 60 kids, okay? And it appears to work. Again, we got to start with something. I'm not saying it's perfect, but I think it's the first step, and we go from there. So formula number 1 is that you have absolute criteria must be present. That's a sudden onset. And then you have 2 major criteria. Formula 2 is in those rare cases where the sudden onset could not be properly established, and there are few of those, okay? What you do is you use 2 major criteria, and then you use 3 minor criteria from these 2 groups, and one of these criteria from each group must be present to confirm the diagnosis. Finally, positive gas titers, relative or absolute leukopenia, positive ANA, elevated IgE, okay, are something that is a contributory evidence, but I don't believe at the time it's necessarily determining evidence. Finally, and I'm just mentioning it, opening for discussion, there is a question about positive Epstein-Barr virus titers in very small children. Let me give you an example. 3.5 years old boy wakes up in the morning and tells to mom, I'm going to eat tomorrow. And he does not eat whole day. Mother doesn't panic. Well, he has a thing. She wakes up in the morning, makes him a breakfast. He said, no, I will eat tomorrow. So he doesn't eat for 4 days. 5th day, refuses to drink. At that moment, mother takes him to the emergency room. has, central line put in, treated as, anorexia without Pandas because they didn't even consider it. Well, that child in its workup had streptococcal titers that were negative, but did have a significantly elevated both IgM and IgG. Now, for 3.5 years, for let's say 13 years old child to have a positive IgG for Epstein-Barr virus is nothing unusual. 3.5 years old child with positive Epstein-Barr virus, it is unusual. So I believe it was contributed. So this is something to think about and test for, especially in the younger children. Final reminder, there is so-called, we call it Alice in Wonderland syndrome, that has been described in mononucleosis, okay? And this is something that could be connected, actually, to the onset of anorexia in Pandas patients, but that's gonna be left for the other discussion. Finally, as a practitioner, you get a patient, you identify certain symptoms, you suspect patient has Pandas, where do you go from there? Well, yeah, my suggestion would be to use a simple, well-organized laboratory approach. So I think it's perfectly fine to do the CBC, ASO titer, anti-DNSB, streptozyme titers, Epstein-Barr virus, and then you go with antinuclear and immunoglobulin panel. Now, let me explain you something. I don't take immunoglobulin panel because I'm worrying about elevated IgE or I'm worrying about the selective immune deficiency, because a lot of these patients have had a history of chronic or repeated infections, and they're bound to have low IgG and possibly decreased subclass 2 and subclass 4 of IgG. But what happens is you are working with an 8-year-old child who is acutely ill, and there is a chance that the child might need to be treated with IVIG or plasmapheresis, and to do that, you do need this immunoglobulin panel. So my feeling is, why to stick the child twice if you can get it done once, okay? Finally, Mycoplasma pneumonia, it's one of those titers that we really don't know what to do with, okay? If you take an average population in the Pandas age group, you're probably going to find about 65 to 68% will have a positive IgG titers for Mycoplasma pneumonia. The reason I have been fascinated with this particular titer is that in the past I identified about 6 patients who had a severe aggressiveness, and they had actually physical violence symptoms, okay? And they all had a significantly elevated both IgM and IgG for Mycoplasma pneumonia. What is the significance of that? I don't know, but maybe you can find out for me, okay? Finally, so actually, CAM kinase, what is Dr. Cunningham test, okay, Mycoplasma pneumonia and circulating immune complexes actually are optional tests, and in a normal course of the workup are not necessary to be done. Now, there has to be some kind of organized course after you make the presumptive diagnosis of Pandas. Well, what do you do with the kid? I mean, you can't send the child home with diagnosis and say, well, that's it. So what I would suggest to do, and I believe it might work in just a regular office, okay, is after diagnosis is confirmed, to the best of our knowledge, I generally like to start these patients on 14 days of amoxicillin clavonate. And the reason I like to use amoxicillin clavonate is because of the Rothstein's report on neuroprotection that beta-lactam antibiotics exert, okay? I give them 14 days, And you should observe what happens to the patient. Again, if patient is 75% or better, you leave the patient alone, you follow. Okay? However, if there is an insufficient improvement, you follow that with a prednisone burst. Again, just to remind you, it's 1 milligram per kilogram for 5 days. And then you observe for additional 2 weeks. If the child improves, you leave it alone and you just follow it. However, if there is, I apologize, I'm having the wrong glasses because I broke my glasses half an hour ago. If none of this happens, that means if the patient does not respond to antibiotics, but responds to steroids, if the response is temporary or insufficient, then you have to look what would be the next step. Now, let me give you just a few experiences that might help you out. In a course of years, I have followed a number of patients treated with antibiotics. Unfortunately, I'm yet to see one who has been cured with it. Antibiotics, the longest period between the positive response to antibiotic and the recurrence of symptoms has been 4 years and 3 months. So during that time, this particular child was perfectly asymptomatic. The longest improvement following the steroid burst I have seen is 94 days. Okay? Sorry? No. Antibiotic was that killed. Okay? So, what are really the indication for IVIG treatment? Okay? Well, first, you need to confirm the diagnosis. Okay? I apologize. I'm done in 7 minutes. Okay. Let me go through it very quickly, okay? So, indication for IVIG treatment are pretty well defined, I believe, and I think my colleagues would agree with some of that, is first you need to confirm the diagnosis. You would like to have a presence of supporting evidence that was cited before, okay? You have to have a failure to respond to antibiotics. It's none or insufficient, so that can happen after first episode, second episode, or fourth episode, okay? And you have to have a failure to respond to steroid burst. The degree of current, that means at the time, debilitation, has to significantly impact patients' family life, social life, or a patient's academic life. So failure in any of these areas would be an indication for the IVIG. As I would agree with Dr. Latimer, patients with anorexia represent a completely different group, and actually they should be treated as soon as possible, and I would not go through any of these steps, okay? IVIG treatment protocol that I use is 1.5 grams per kilogram, okay? I divide it in 2 equal doses, and I give it on 2 consecutive days, okay? Post-IVIG protocol, I used to keep the patients on preventative antibiotic for a year. During that time, we encountered a 10.7% recurrence rate. Then we watched those patients for 1 other year and found that the recurrence rate went to 22%, okay? So now currently I'm using 2 years preventative antibiotic. Okay. When you're done, you have to define, was it successful or not? And actually, here are the ideas, okay? Treatment was deemed success if there was a minimum 75% reduction in all previously reported symptoms, and there was a resumption of normal, age-appropriate academic, family, and social life. Treatment was deemed a failure if any of the following was still present at 12 weeks after the treatment: 50% or less reduction in any previously reported symptoms, inability to resume any of the normal age-appropriate life activities, okay, and they're listed there. Now, treatment result on my group, and I'm going to go through them very quickly. 76.1% was the success rate. Inconclusive results were in 13.4%, and failures was about 10.5%. 12.7% of patients originally considered a success required a second treatment during the first year following the initial treatment. The 20.5% relapse rate was reported 2 years following the treatment because the protocol did not include the 2 years antibiotics. Out of these patients requiring the second treatment, 71.7% okay, had a documented non-adherence to the preventative antibiotic or had an outright breakthrough infection. And just 5 minutes, I have 4 minutes, okay? Finally, I do have a specific group of patients that are aged 16 to 32. In that group, we had 38 patients, and they were treated with IVIG after they satisfied all the previous criteria. Interestingly enough, IVIG did work in a good number of patients, but as you can see, the success rate has gone significantly down to 60% or so, okay? But interestingly enough, the recurrences were much less frequent than we saw it with the previous group. Finally, the side effects of the treatments were actually pretty minimal. In my group, we did not see a single case of aseptic meningitis. Before introduction of methylprednisolone as a post-IVIG treatment that we give a single dose, we had about 85% incidence of headache that has gone down to maybe 15-20%, and all other side effects, vomiting, etc., have decreased tremendously. So my suggestion would be to consider using methylprednisolone at the end of the infusion. It could save you a lot of troubles. And last thing is, well, you have to wait 3 months. The parents are anxious. Is it working? How do I know it's working, etc.? So here are actually the positive outcome predictors. If the group is 6 to 12 females or 6 to 13 males, that appears to be the group that is responding the best. Those patients, if they have preserved this up and down in symptoms, Vex and Vine pattern, are more likely to respond well than patients who have their symptoms stuck, okay? Finally, positive response, significant positive response to beta-lactam antibiotics at the time of diagnosis is a positive thing. And the post-IVIG, I generally obtain 2 weeks after IVIG, I obtain the IgG levels. If the IgG levels are 50% or more higher than the initial IgG level before IVIG, that is a positive outcome predictor. And that would be it. If there are any questions, I will answer them later.
Bene, un sincero grazie al professor Kovacevic per la sua chiarezza nell'esporre i suoi dati.
Okay.
E c'è spazio per solo 2 domande brevi e delle risposte altrettanto brevi.
Allora, buonasera a tutti, sono Alessandro Pedicino dell'ospedale di Ostia. Sono un otorino, quindi sono prestato a questa materia. Volevo chiedere una domanda al professore riguardo alla velocità del suo protocollo di terapia delle immunoglobuline, delle IVIG, e se la velocità lo consente, se è possibile effettuare la terapia in day hospital. Voglio dire, cioè mandando il paziente a casa nella notte fra una seduta e l'altra.
Right. Generally, how I do it, I have a patient admitted to the outpatient department at 6:30 in the morning. Generally, we are done by 1 p.m. I send the patient home. They retain the HEPLAC, overnight. We readmit them next day, give them the other half of the infusion, and they're done. So the total hospital stay is about 14 hours over 2 days.
Perfetto. E la velocità con cui manda le immunoglobuline?
Well, I think if you look at the old references, the old reference was allowing to go to 9 milligrams per kilogram per minute. That is absolutely not applicable in pandas. Actually, ideally, what you should do, you start the infusion at 0.5 milligrams per kilogram per minute for 30 minutes. You increase it to 1 milligram per kilogram per minute for 30 minutes. You go to 1.5 milligrams per kilogram per minute for 30 minutes, and then you hit the full speed. And maximum allowable speed, in my opinion, is between 4 and 4.5 milligrams per kilogram per minute. So it's a half of what is normally recommended.
Grazie.
Ci sono altre domande? Alberto?
Sempre Alberto Spalice, Roma. Dunque, se ho capito giusto, forse siamo a una definizione di protocollo che potremmo utilizzare tutti insieme. Allora, si comincia con l'antibiotico per bocca per 14 giorni, giusto? Dopodiché si aspetta, vuol dire aspettare. Aspettare 10 giorni, 15 giorni, un mese?
Now, let me go over that again. After workup has been done, and after diagnosis has been confirmed, we give a child beta-lactam antibiotic, therapeutic dose, for 14 days.
Okay.
And we assess the child at 14 days.
Okay.
If at 14 days child is 75% or better, we just stop and watch it.
Okay. This is also my opinion.
Right.